Okay, welcome everybody to this one-off West Yorkshire Integrated Care Board shadow meeting. As you know, that we are not in a statutory form as an Integrated Care Board, an ICB, until the 1st of July. And today's meeting is for information, but also to have foresight on what we are going to have as oversight and needing assurance on as an Integrated Care Board for West Yorkshire, alongside the 41 other Integrated Care Boards in the country. Thank you to everyone for joining us today. We have members of our Integrated Care Board today who've been appointed, going through open and transparent processes. And we also have people today who are interim representatives and will be going through a partner nomination and sector representation nominations process shortly. Now we're out of the pre-election period. So for members of the public having a look at the documentation, you've got a full list of the attendees today. We also have in attendance, we have Fatima Khan-Sham representing the Race Equality Network. So think of her as a critical friend and advisor to us today. And we also have Harris Sultan with us today, who is joining us on the non-exec member side on the next director placement with us. We do have some apologies today from colleagues. I know that we have Becky, Bill and Tom, and we'll note those formally in the minutes of the meeting as well as online. So we have started slightly late due to a technical difficulty. I apologise, colleagues, but we will make sure that we are efficient and productive with our time today. Can I just ask if there are any declarations of conflict of interest in relation to today's agenda, please? Jane.
Yeah, thanks, Kathy. Can we just note my day job role at the University of Leeds, and there is reference, I think, to some work with us in your chair's report today. There may be other references that I've missed, but if we can just note that, that'd be great. Thank you.
Thank you. Are there any other conflicts of interest in relation to today's agenda? No. Okay. And for ICB members, Integrated Care Board members here, and for members of the public, to be assured, we will have a matrix of interests that will accompany our first statutory board meeting on the 1st of July, so that we can openly and transparently share various perceived actual conflicts of interest or ways in which we are proactively managing conflicts of interest, as Jane has given an example today. So thank you, Jane. So I'm going to move us on now to questions from the public. So this is the first time we've invited questions from the public in relation to the Integrated Care Board. We promoted the opportunity around a week in advance, which was at the same time as when the documents for this meeting went out online. We particularly went out to networks that we know, particularly through our partnership board, as well as other networks, and promoting it via social media. And I hand it over to you now, Stephen. I think we have 3 questions that are going to be read out.
Yes, Chair. We've had 3 questions, which I'll read out shortly. We've also received some questions after the deadline closed from Jenny Shepherd, Chair of Calderdale and Kirklees 99 call for the NHS. We've been in touch with Jenny to explain that although we're not going to deal with the questions in the meeting, we'll be providing a full written response to her questions. So in terms of the questions we've received 3 from Lindsay Mabin, who's a community dentist and a staff governor at Bradford District Care Foundation Trust. The first question is in relation to suicide prevention, and she asks, in West Yorkshire and Harrogate, are near misses being well recorded? How do we compare with other districts? And what is the ICS doing to encourage shared learning from these incidents? And I think Sarah Munro's just going to give us a brief verbal response to that question.
Thank you. Sarah, would you introduce yourself before you answer the question? Thanks.
Yeah, good morning. My name's Sarah Munro. I'm the Chief Executive at Leeds and York Partnership Trust, and I'm the lead for the Mental Health, Learning Disability and Autism Collaborative for the Integrated Care System. So 2 elements to the response. In terms of real-time surveillance, we do have a group set up, which is chaired by Deputy Director for Public Health in Wakefield, Steve Turnbull. We've invested in a suicide prevention data and insight lead within the police. So this is using the NHS monies. We now have a dedicated post, and they are improving the quality and the detail of the information that we get from the police of suspected or actual suicides. And that's including data on protected characteristics, location and method. Unfortunately, we cannot access data for what would be considered a near miss through those routes. It isn't available routinely. We are using that group. We are seeing improved connectivity into bereavement services for the data that comes through for when there has been an actual suicide. In terms of where we can collect data on near misses is our mental health trust do record this as incident data. Where there is a near miss of somebody in contact with any mental health services. And we now have a secondary mental health network group across the organisations where they are sharing the information and the learning both from near misses and from actual suicides and any other soft intelligence as well. And they're planning to take a thematic review of case studies of deaths, and in particular looking at that interface between primary and secondary care, of where we believe that there might be opportunities to be able to respond to people sooner. So that's the position that we're in. We don't have any access to any benchmarking data for this kind of information from other places to show how we compare.
Okay, thank you. And as I said, as when we had our pre-meet, I'd really encourage you as ICB members and those present today as our advisors and representing stakeholders, if there are themes that you would like to take through, particularly coming out of public questions, our presentation from Health Watch today, as well as reports later on, please let us know, and that's something you can put into the chat box. So thank you, Sarah. It's a work in progress, as well as good areas of practice, as well as areas of improvement that you're working on. Thank you. Stephen, the next question, please.
Yeah, the second question is, many service users and carers in our district have reported poor experiences in A&E for mental illnesses. What mental health training do we already have in place for staff in acute trusts, and how are we improving the education for these staff? Do we have shared learning at place and at a regional level? And I think Julian Hartley is going to respond to that for us.
Yeah, thank you very much, and a really important question. Across Wyatt and the Trust in West Yorkshire, I know there's a real focus on this issue. Just by way of illustration, some of the things that are happening in Leeds teaching hospitals, and I know there are numerous examples across other trusts, is we have a corporate mental health team who provide advice, guidance and training to our clinical teams. We've recently commenced a quality improvement de-escalation collaborative, which includes the emergency departments and admission wards, including a focus on mental health and training programmes for staff. And some of the examples include places on the Good Sense training package, a 2-day face-to-face programme that focuses on de-escalation techniques, Leeds survivor-led crisis team, who delivered significant numbers of training on managing self-harm and suicidal ideation presentations. We had well over 100 nurses attend, with many from emergency department and acute areas. Personality disorder training, 3-day course, and mental health development programme rolled out to band 7s with plan to include band 6s. We also have around 15 mental health clinical support workers working across the emergency departments, and these staff increase the support available for patients with mental health needs, as well as recruiting mental health nurses for our wards with high numbers of patients presenting with mental health needs. Now, I know that as Wyatt, we share our approaches, and this question will prompt at our next meeting a discussion and sharing of what we're all doing. I'm sorry I can't give you absolute detail on what every trust is doing across West Yorkshire, and I'm using these as examples, but I do know that many programmes are underway in the other colleagues across Wyatt. We'll use this question as a prompt to challenge ourselves about what more we can do. It's an increasingly it's an increasingly prevalent issue, of course, in EDs, given the challenges that we're currently facing across the patch. But very happy to perhaps come back with a stock take across the whole of Wyatt, Cathy, on what we're doing in relation to these this important issue. So I hope that gives the board and the questioner some assurance we're thinking about this and taking steps to tackle the challenge that the questioner has set out. Thank you.
Thank you, Julian. Just would you explain Wyatt for any members of the public who might be watching the meeting?
Yes, indeed. Yes, apologies. The West Yorkshire Association of Acute Trusts is a partnership of the 6 hospital trusts across West Yorkshire and Harrogate. We work together in the interests of patients. We share approaches. and we aim to deliver the best possible acute services, working in partnership with other organisations across the ICS.
Great, thank you very much. And I know when we become a statutory board and organisation, we'll be looking at thematic areas, and Rob talked as our Chief Exec designate about looking at risks as well as opportunities, and we'll look at them by place as well as thematic areas. So hopefully that can weaved into a presentation from the acute group of providers within our patch in the future. Thank you. Stephen, I know we've got a third question. Would you cover that one, please?
Yes, the final question is staff sadly at times face aggression from service users. How does West Yorkshire compare to other districts, and what are we doing about the challenges that staff face? I think James Thomas is going to pick that up for us.
Okay, thank you. Thank you, Chair. So my name is James Thomas. I'm the Medical Director Designate. I'm pleased to be here today, and thank you, Lindsay, for this question. So I think as we recover and live with COVID, we have seen kind of the increasing demand, but also the frustrations for patients, and sadly also the impact on facing aggression from service users, as kind of in the question there. We know that this has indeed been challenging times for all of us, patients and staff, and we've seen and heard a lot of impact of aggression on our staff. I know that's kind of just one conversation, one bad conversation can be enough to hurt, and know that we all need to take time to consider our behaviours and how they impact on others. We are aware that there have been increasing levels of abuse against our staff, and we've heard and seen this especially in general practice and across our community pharmacy staff. We don't have figures, and I'm unaware of any collected data regarding recorded numbers of aggression or the reasons why people leave. Therefore, I can't really compare the data in terms of us with other areas there. However, we have heard and are seeing the impact of aggression on our staff, and that I have received, and so that's prompted West Yorkshire Health and Care Partnership to launch the Leaving the Gap campaign, which you may have seen over surgeries in community pharmacists across all our organisations, which is a campaign asking people to take a moment to think before speaking with our staff, highlighting the danger of driving staff away from the health and care system, and how this won't help anyone and will only make the situation worse. So this campaign has been widely publicised. It's been really well praised and thought of, and is currently just going through the evaluation process at the moment, and we should have that back later on this summer, and we'll publish a report of the campaign, and I'm very happy to come back to the board with that report to kind of highlight the reflections from the campaign. Chair.
Great. Thank you very much. And I think this is going to weave it. I know we have Kate Sims today, our new Integrated Care Board Director of People, not joining us till June, but thank you, Kate, for joining us today. I think that can be also included in future people plan reporting alongside staff survey results as well. So thank you. And I suppose just to record, we had some feedback earlier before we started the meeting today on how we could develop and improve the way we hold integrated care board meetings. I know Julian and Rachel particularly talked about citizens' voices, carers, patients' voices, but I suppose there's also we need to consider staff voices as well and how we bring them through. So we'll work to make sure that we're being as creative and as deliberate as possible to make sure that those voices come in as soon as possible into meetings. Okay, thank you for those questions. Stephen, you did say that we had some other questions submitted after the deadline. We will respond to those directly to the individual who asked them, as well as to the person who's asked these 3 questions that came in before the deadline. We'll give them written responses, and they'll also be on our website as well. Stephen, is there anything else to add before we move on?
No, I don't think so, Chair. No, that concludes the questions.
Brilliant. Thank you very much. And something from my point of view and working with Stephen is to make sure that we are promoting as far and wide the opportunity to ask the Integrated Care Board questions. So if you've got any suggestions on how we reach out to new networks as well as existing ones to let them know about this opportunity, please let us know. Okay, so our next item on the agenda is looking at citizens' voice. Warm welcome to Hannah Davis, who's Chief Exec of Health Watch Leeds. Thank you for joining us today, Hannah, and for all the work that you and colleagues across all the Healthwatch organisations in our partnership do. I know that you've shared a report with us in advance, which my colleagues I have read through and absorbed, and you've got a number of recommendations there, but you've also got a film to share with us as well. So I don't know if you want to share anything, Hannah, before you get into the film, and then I'd really like to invite a discussion from our Integrated Care Board members. But over to you, Hannah.
Thanks, Kathy. And yeah, I'm here as the interim Healthwatch representative here, and it's great to be here. And I suppose just to build on the conversations already, we as Healthwatch and as a health and care partnership really believe that the voice of people needs to be central to decision making. It isn't just a one-off story at the beginning of a meeting. It's relating. It's about driving the agenda. It's about relating all the decisions that are made at West Yorkshire to actually how it feels and what it will mean for the people of West Yorkshire. As local health watchers, we've been part of the West Yorkshire Health and Care Partnership for the past 5 years, and our role is to bring people's experiences. But again, we've got a really strong ambition about how we might develop that. So really welcome any thoughts and ideas and reflections about how we further take that forward. The paper that we've circulated is we've been part of all the key West Yorkshire boards, but we were part of the Strategic Oversight and Assurance Group board over this past year, and really were asked and challenged and championed to bring the issues that people were talking to us about. And the report summarises those key issues that that people talk to us about, and I'll just quickly go through those. The experiences, as we know, during COVID, the huge transformational change to non-face-to-face delivery, that was huge. Ensuring we get digital right for people is absolutely key, and potentially don't drive forward health inequalities and access inequalities by the move to digital. The lack of dental access, particularly in being able to register with a dentist. As Healthwatch, it's one of the key things we hear on our advice and inquiry line. People given 5 years waiting time to be able to register with a dentist. Which actually has a huge, brutal impact on people's lives, and again is an equalities issue. People's experiences of waiting for treatment and the vital role that effective, compassionate communication plays. The experience of people living in care homes during COVID, particularly highlighting some of the most isolated, unheard experiences, and how, as a health and care system, we really need to support care homes to return to those welcoming, inclusive environments. People's experiences of accessing GP services, and again, it's in part of the report, but actually that's one of the big themes that we hear in Leeds. We've just gone out to do the Big Leeds chat. It was the #1 thing that people talk to us about, and again, I would support some of that conversation around frustration around access, and potentially why some people, some of the really inappropriate behaviours that we're seeing. Mental health, absolutely a key theme that we hear, and something that we heard through the long-term planning engagement that we did those years ago, and continues to be a key theme from the people of West Yorkshire about how do we get mental health services right and get that parity for mental health services. And then finally, the impact of poverty on accessing health and care services. And again, that feels like a really key theme as we go forward, not just the impact of accessing it, but the impact of poverty on having to access health and care services going forward. So that's just a whistle-stop tour, and I think we did make a series of recommendations, and part of the recommendation of this report is that there is a follow-up report to see what action has taken place. But I suppose one of the things, and I'm talking really quickly now because we've got a limited time, but one of the things we really wanted to bring was the people of West Yorkshire into the room. It's one thing to hear it from us as Healthwatch, but it's another to hear people's experiences. In Leeds, we've developed a programme following the CQC system-wide review in Leeds, which asked really a brilliant question, which was, how does it feel as an older person moving across health and care services in Leeds? And since then, we've been doing a lot of work to understand that, and part of that has been following people in real time, their experiences. And I've brought this one particularly because it describes integrated health and care, and that's what this is all about, which is about joining up health and care, and it crosses boundaries as well. So the video is actually 7 minutes. It's quite a long video, but hopefully there's a lot of really useful information that will frame some of our discussions going forward. Adam and Emma, who share their story with us, who actually should be on Gogglebox, I think they're so engaging. But they live in Wetherby, so actually they're Leeds residents, but their services straddle boundaries, which again is very relevant for the West Yorkshire board. And I suppose just to say, from a Leeds perspective, we're really highlighting the 3 C's, as we're calling them, the absolute vital role that effective communication plays in delivering health and care services, and the need to really focus on that. The fact that care needs to feel more coordinated, and the fact that care should be compassionate. So I'll just leave it with that opening. Thank you.
Thank you very much, Hannah. And this is the beginning of a conversation at Integrated Care Board level, isn't it? Thank you. Is the film ready? Thanks, Lauren.
So sorry, Kathy, I'm just going to do that again. I'd forgotten to tick the box to include the audio. Sorry, please bear with me. I'll be one moment.
Adams update, November 2021. How have you been over the last 3 months?
I was deteriorating mental health-wise, and my care coordinator was rude before she left and tried to put stuff in place, but none of this materialised. So this last month it's been trying to navigate finding a way to get some more help, but not succeeding at kind of any point really.
How was your experience of trying to get help from the Harrogate Community Mental Health team?
The care coordinator made an appointment for a duty worker to call you, and then they never called, even though Emma waited all day for them to call. And then the week after, I tried to chase up why they didn't call with the reception to find out what's going on, who then got in contact with Emma's psychologist, who she sees once every 2 weeks, who then rang Emma, misunderstanding the reason why I'd rang, asking if Emma needed any help, or if she wanted care coordination, still wanted it or not, despite her previous care coordinator saying very specifically Emma still needs a new care coordinator whenever that person becomes available. And then that kind of it got all very messy. She did arrange for Emma to speak to a duty worker the following day, who then got back in touch with the psychologist and said, I have some concerns about Emma. And then even though the duty worker had expressed those concerns, again, they hadn't been picked up again. And then you had an appointment with the psychologist on the following Wednesday.
And Adam had to come with me because I was mute.
So we spent an hour of this really quite precious resource of an hour of therapy, trying to explain away the previous week of misunderstanding and miscommunication and incorrect ringing of who did what and why the duty worker didn't ring in the first place, and trying to almost cover the backs rather than addressing the right here, right now, Emma's not talking, she's clearly not okay.
I kept writing on my phone, I don't want to talk about this anymore. I want to, I don't care anymore in this session that you didn't ring or somebody didn't ring. I just want to know where we're heading now.
Yeah.
Right now.
And then almost like something out of a sitcom, the therapist basically got up and said, right, time's up. And then she almost very abruptly got up and walked to the door and to show us out, basically. Almost like she was angry with us.
That upset me as well, because I didn't understand. I thought she was annoyed.
Yeah. I said to the psychologist, I'm not happy leaving right now, as Emma is, because she's clearly not well. So I was like, what can we do? And she's kind of like, well, I suppose you can see a duty worker. So I went to the reception, asked, can we see a duty worker, because Emma's really struggling at the moment. And thankfully there was somebody available, so we were happy to wait. Obviously, and she came and spoke with Emma for up to an hour and talked about what we're doing right now. We went through all the situation, and then the duty worker listened to that and it offered, like, what are you doing today, what's the plan for tonight, and we explored some options, because crisis team is a difficult option for you given previous history.
So when I made the decision that I didn't want to have to go for a psychologist to get referred, I said, can we ask if we can see the doctor instead? Because right now I will agree to do a medicine increase just for a short while until it gets a bit better. And so Adam rang up about that, and they said, well, we can get you to see him in about 4 weeks. And so I was just like, there's no point in that 4 weeks. But they wouldn't even let my GP. I had to wait for this appointment in 4 weeks' time. I couldn't even go through my GP and get it sped through. And I don't understand that. The whole point of when I've been in services, the whole point is that you need to reach out before you do something. You need to get the help before something happens. And then in reality, when you try and do that, there's nothing for you. You can't do anything before it happens.
Did you feel listened to?
the duty workers and the psychologists kept saying, you're stronger than the voice. Like he can only get you to do stuff to yourself. So if you end up doing something, it's only you that's had that power, not him. I find it hard enough to explain. I can't explain to people why I have to follow something that's only in my head and I know can't physically hurt me anywhere else. It's very hard. How are you meant to reach out to someone for help in services for saying that you're struggling and you can't cope with the voice when their only response is be stronger than the voice?
And how am I going to do that? Conversation with your psychologist when it got all messy. They kept talking about like preparing for discharge and stuff like that, but no one's had the conversation about what we've had. That conversation last November about what we need to achieve, what Emma needs, but they've not done that yet. But then they're talking about it again, like we're getting ready to
when
do
you're
it.
in crisis as well.
Like, well, yeah, it's like, well, you've not even you've set. So you've asked us what the outcomes need to be. You've not worked on the outcomes, and now you're saying, well, we've done it. I'm like, no.
And she kept asking, can we get Adam to leave? She didn't want you in that appointment. She kept saying, can I just get to speak to you on your own? It's like, no, I want Adam here because he can speak for me and he can also help me reality check after the appointment. We've had people who seem to be pleasant and kind and stuff. It doesn't feel like they've actually listened to what we've been trying to get help for.
Our services joined up.
My old care coordinator was helping us get a referral to Leeds perinatal services, kind of support us on how to make an informed decision on like the kind of our future really. And then because my care coordinator left, I don't know where that referral's gone now. So you're meant to hear, I think, within 2 weeks. I've not heard, so I don't know if it's been sent or anything. I would have expected to have been referred to the Harrogate one, which is joined up with my CMHT team and my care coordinator and all my mental health notes and everything. But they tried to refer me to the Harrogate one, and I was told I'm a Leeds patient, so I have to go to Leeds mental health perinatal services, which is a little bit confusing. To be sent to a different trust who doesn't have any notes on me, historically have never asked for my notes from Harrogate when I've been for them. So like when I had my Leeds autism diagnostic services, my referrer was Harrogate, but they didn't even ask for any notes or even why my referrer was referring me, because it was too difficult to get the notes from Harrogate. So it's very worrying to me that I can't be seen by the perinatal team attached to my mental health team I'm already with, and they have to be sent somewhere else.
If you could have changed one thing to make your experience better this month, what would it be?
I think if we could change one thing, I think it's about hearing what we say, but then acting on it and not getting wrapped up in the bureaucracy of, the criteria and all that sort of stuff. Just do stuff, because that delay can have a profound impact on someone's health and well-being.
Yeah, I don't understand why it takes so long. Why everything has to be so delayed so you can actually get some proper support.
So just reiterate, thanks to Adam and Emma for sharing their story, particularly of frustration in trying to get access timely support. Hannah, is there anything that you want to say? And then I'd very much welcome colleagues to share comments, responses, questions. Hannah, is there anything you want to follow up on?
No, I don't think so, other than there's a series of videos which, if people have got time to watch them, I'd really recommend, because it's fascinating and really insightful to watch Adam and Emma's journey, some of which is very positive as well.
Okay. Yes, they did mention people who listened and were compassionate, but there was a continuing theme of, timely access to services to gain their support and being listened to rather than getting caught up in the bureaucracy. Rob, over to you.
Yeah, just so thanks again to Emma and Adam for their story, and I think we've as Hannah says, been tracking their progress for some time. I think as a board, this is the ultimate test of what we do, isn't it? Do we see Adam and Emma feeling a difference in being heard, a reduction in the handoffs and bureaucracy around care and how it's coordinated, and how do we deal with people who live on the boundaries of places? So there's some real real tests for us. But I think it was important for us to start with the people we serve, which Hannah's done really well, and Adam and Emma have set out some of the issues for the people we serve, and that we didn't have a varnished story that said everything's brilliant. Because one of the reasons why we have integrated care systems and are thinking about integrated care is to resolve some of these issues. And I know that we've got lots of positive stories and lots of positive examples, and there's still much more to do. So as a partnership and as a board, as an organisation, I hope that our ultimate test will always be that people like Adam and Emma are seeing and feeling a difference. But I also think that there's some nuances in some of the things they say which always strike me as worth having a look at. So things like duty worker sound to me, you know, as if it's a service which isn't first class, but that's the label. You know, the people who are providing that service are qualified, good people who are compassionate, but the way we describe them, I think, sometimes devalues what they do. It's a personal view. So I do think we need to hear what they've been saying to us and use this as a benchmark for the future.
Thank you, Rob. There's also a theme there on practical things like a shared care record, isn't there, as well, which I know colleagues are working on. We've got other hands up, Rachel and then Mel.
Thank you, Chair. My name is Rachel Spencer-Henschel. I'm the Director of Public Health for Kirklees and representing the West Yorkshire Directors of Public Health today. I think just echoing Rob's point about how people are so much more than their job titles, and actually it's about the relationships that they build with people like Emma. And I think that it was a really powerful video, and I'm looking forward to reading the others. In relation to the report, I just wanted to say that that's very much reflective of the conversations we've been having at a local place level in terms of the areas that you've highlighted. I'm very keen to understand the inequalities within that, because I suspect there will be groups within our communities that are more disproportionately affected than others, and I think it's something that as a shadow ICB and as a collection of places we're absolutely front and centre on in terms of inclusion and how we make sure that no one is left behind. So I'd be keen to work on that, and I think that the citizen panel that you refer to in terms of setting that up, I think is a great idea, but I guess the trick is how do you make sure it's representative so that we can include that as part of a number of different ways of getting engagement from our populations. Thank you, Chair.
Thanks, Rachel. That's really helpful, and how we connect this through places, neighbourhoods, and at a West Yorkshire partnership level. I'm just going to take a comment or question from Mel. Then Hannah, you might want to respond, and then we'll hear from Fatima and Sarah. Mel, over to you.
Thank you very much, Chair. And I really enjoyed listening to the experiences of Emma and Adam. And I think what it highlighted to me was, and we just had this conversation, I'm sure if Fatima's going to come in actually, I hadn't appreciated that, as she introduced the item yesterday amongst the sort of leadership team around personalisation. I think it's that issue of tailored care. I think we need to be able to understand that people who have long-standing issues that they live with for a long time, be it a physical chronic disease or a mental health issue, a psychological issue, then the offer of personalisation is a really important one. It's much more of an important thing to do rather than a short, sharp, episodic contact that's required to fix something in the moment. And I think that's our challenge, isn't it, to nuance the offer to better fit the needs of individuals. And I know that there is a plan to do that, particularly around chronic diseases, and Fatima's introducing that work to us that will be very much rooted in the work that we're doing in our respective places around the development of our community offer alongside our primary care offer, because I think they're two really important entry points for people living with long-standing problems.
Thank you very much. Hannah, do you want to respond, and then we'll go to the next set of questions and comments?
Sorry, yeah, I just totally agree with what everyone's saying. I suppose just particularly on the question from Rachel around the voice of inequalities, I think that's what we say within Leeds, and I think that covers in other West Yorkshire areas. It's actually the voice of inequalities that we need to hear. That is the voice that we need to bring forward, and so the work around the People's Panel and People's Network will be that will be the lens that we look at. That's the one that we need to hear. So just to reassure you on that.
Okay, and Hannah, it feels like in your recommendations report, I know you're specifically looking at dental services, for example, but there is something about you keeping, I'm trying to think of the right wording, but you are one of the key voices and critical friends to us in making sure that we truly are achieving integrated care. And I think we've got some great examples, and Rob is really wanting to encourage us to look at the achievements and the great opportunities and good practice, but we also need a reality check as well, and when it's not working, what we can collectively do about it as a group of leaders here today. So thank you. Fatima, Sarah, then Jane, and then we'll move on to the next item. Fatima.
Thank you, Chair. Morning, everyone. My name's Fatima Khanshah, and I have the privilege of convening the Race Equality Network, which is why I'm here today. But I also have a day job amongst many things, and that's the Associate Director of Long-Term Conditions and Personalisation. And as Mel quite rightly read my mind, the reason why I put my hand up was to talk about the fact that there is a lot of personalisation that would really benefit the stories of not only what we've just heard, but individuals across West Yorkshire. And the things that came to mind, Hannah, were things like shared decision making, which in that story would have really helped that particular situation. Really supporting self-management as well. So one of the things that we always hear about are how are people, dealing with the wait to access care, and actually supported self-management, if we get it right, can really support people while they're waiting. I suppose the thing I also wanted to share from a race equality perspective is Rachel's absolutely right about ensuring that we consider everybody's experience and that no one gets left behind, but actually personalisation is a fantastic tool if implemented correctly that mitigates people's access, the barriers that people experience accessing care. So if we personalise things in the right way, then this won't be an issue. But I suppose the other thing I'd like to say as well, because I can't sit in a room and not talk about carers, and it was really lovely to see that carers were mentioned in your report, Hannah. And, we were privileged to be at the House of Lords Adult Social Care Committee yesterday testifying about this. Carers actually have a lot of expertise and insight in supporting their loved one, but are also instrumental in supporting that person on that journey too. And I think from the story that you've just shared, and they were both so articulate, but it just shows the impact a carer can make in that scenario. And I think there's far more we could do on that too. So it's just to assure you that it's very much on our radar, but with the mindset there is far more to do.
Thank you very much, Fatima. Sarah, then Jane.
Yeah, thank you. Just wanted to follow up from the work of the collaborative. Hannah and colleagues have shared the deep dive focus that they've done on mental health with the programme board, and then we've shared it. In particular, there is across the whole of West Yorkshire transformation programme happening for community mental health. So the story from Emma and Adam is key of how do we really change that model, which has been pretty much set in stone for well over 20 years, get that better connectivity from primary care networks through to secondary care, and overcome the fragmentation that's occurred as other specialist services have been developed. Welcome the development, but that just increases fragmentation, and community mental health is the bedrock really of access and support for people with long-term mental health conditions. And also what's really important is key in that is co-production with experts by experience. So across all of West Yorkshire, the programme boards have got people who are currently using, and their carers, or have used community mental health services to help shape and design what that model is going to look like. And that's going to take us a couple of years really, because it's a big culture change for the service. But just wanted to reassure the board that we're very much taking that lived experience to the heart of the changes that we want to make.
Thank you very much, Sarah. Jane.
Yeah, thanks, Kathy. Sorry, I should have introduced myself properly earlier. So I'm Jane Madeley. I'm an independent non-exec member of the board. So it was really great to have that patient voice at the start of the meeting, and the conversation that we've had since then. Just thinking going forward as we continue to ensure that the patient voice comes forward, I think it'd be helpful if at the end of each of those, there is something that just kind of gives us an assurance of kind of what's happened since, not a full story, but just so that we I'm sure people are picking up and doing things, and the discussion would be evidence to that. But I think it would be helpful just to sort of round off a little bit at the end of each of them to say, yeah, this is now being picked up by whoever, and presumably, response to those who are offering their voice to us in these kind of situations. I'm sure it is being done, but I think it'd be nice just to say a little bit when we come to the end of these sessions, so people are confident and can see what's happening as a response to it. Thanks.
Thank you, Jane. I think it's great. What's the story that happened afterwards? Okay, thank you. So Hannah, we note the report, we note your recommendations. I think there's also then a broader theme, isn't there, on integrated care overall, testing it, continuing to test the boundaries of it and its practice, which we'd really welcome Healthwatch's involvement, including you. We note that you are working on a systems panel or network to link alongside the Integrated Care Board as well, and a need to monitor the progress of the recommendations, which we'll put into our work plan as an Integrated Care Board, and make sure that we have meaningful discussions in making sure that delivery is taking place. Okay, thank you, Hannah. We appreciate you joining us for our shadow meeting. Okay, so next item on the agenda is Chair's report from me. As I've shared earlier in our pre-meet, this is for information. It's a demonstration of good governance, and particularly for a number of you who've been involved for many, many months, a historical record of how we have gone about recruiting Integrated Care Board members so far. It's still work in progress, as I said at the start of the meeting. We do have interim representatives here today, and we've been delayed in appointing sector representatives, for example, due to the pre-election period, but we can now, with NHS England guidance, take that forward. We will be having a report later from our only shadow ICB Integrated Care Board committee that exists at the moment, which is for remuneration and nomination. And we proactively set this up because of the amount of recruitment that was taking place, to make sure that we've got a place for scrutiny, oversight and assurance in the work that we're doing, as long as it's first of all in line with NHS England's requirements, but also secondly in line with our values and our behaviours as well. And we're really grateful to so many of you for being involved in that, including the Race Equality Network and Fatima particularly chairing so many different stakeholder panels for us. So we feel that we've had a robust process, which is what that report particularly evidences. One thing I wanted to share with you is that I have paused the recruitment of the 4th non-exec director. I think you all are aware of this. And it's because we've got a commitment, as you know, in one of our 10 ambitions to make sure that we have diversity in our leadership in our health and care partnership. And I very much wanted to pause that recruitment and rethink. The Race Equality Network have been very supportive. Many of you involved in the process have responded informally and formally through a survey. And we started the recruitment for that 4th role last Friday in deliberately a different way, particularly aiming to recruit applicants from minority groups who have a connection to West Yorkshire. So thanks to everyone who's been critical friends to us. Rob and I particularly met the Race Equality Network about 10 days ago. We've had a very open and robust conversation about what we're going to do to achieve our ambition together. So that's one example. There's a lot more work to be done, and this is I think, Fatima, you talked about it being a journey, but our colleague Keith Ramsey from Mid Yorks is going to come later to talk about the work of the Shadow Committee and a number of principles that we have agreed through that committee. I also wanted to say, for the record, this is more for the minutes, that we are on track and ready to be a statutory organisation from the 1st of July in line with NHS England guidance, and also in preparedness for us in being the way we want to be for our West Yorkshire partnerships. That includes our place committee structures and having independent non-exec, as it were, or lay member oversight of that. So we know Hilary is here today, but she's going to move on to the place committee in Kirklees, particularly to support them. And we have now recruited and openly announced, let me check my numbers, 3 out of our 5 independent place committee chairs. One we recruited for last week in Leeds, which Tim will be announcing shortly over it, who's our place lead for Leeds and Bradford District and Craven, led by Mel Pickup. Our place lead for over there will particularly be interviewing on the 10th of June. So we're on track there. And I've received really welcome feedback from colleagues across the partnership on how we're building in independence, accountability and scrutiny, but also doing it in our West Yorkshire way as well, which by making sure we're nominating people that we feel can represent us well and achieve what we want to. So I think that's the overview from me there. There's a lot of information there, but there's particularly there for assurance. And the last thing I want to mention in my report is we've received a lot of public inquiries about whether people and organisations from the private sector will be involved in our integrated care boards and related committees. That is absolutely not the case, and we've got a statement on our website to support that. No one with a commercial interest and from the private sector will sit on our integrated care board or our committee. So I just wanted to record that. And Karen, thank you very much for your support in responding to those queries that have come through, which you know have come through to other integrated care systems as well. Okay, anyone have any questions at all? No, thank you for bearing with me as I got a number of things into the minutes there. I appreciate that. Okay, I'm going to hand over to Rob now for his Chief Exec Designate report.
Hello everybody, my name's Rob, I'm the Chief Exec Designate, so apologies I didn't introduce myself on the previous intervention. You've got a very substantial report in front of you, which will not be the way that this occurs in the future. I was very keen, in the absence of us having a balanced scorecard showing performance, finance, what's happening with the workforce and what's happening with quality, and in the absence of a current risk register or board assurance framework, that we put as much detail on some of those things into the public domain as possible. And this report gave us an opportunity to do that. So it's a long report that covers a lot of ground, and in the future the Chief Exec's report will be supplemented by, a balanced scorecard which gives all those performance metrics, a risk register and a board assurance framework. So it'll be a lot shorter, sharper report. So one of the things that boards are always conscious of is how much material and paper they get, and just to reassure you that you won't be getting 15-20 page reports from me in the future. What you will get, though, is a report that sets out the context within which we operate, which helps to shape the conversations about items on the agenda. And today we've got a discussion about plans and planning for the next year. And it's important that we see that in the context within which we operate. And what the report does, and I won't go through any of the detail because I know you've all had it for the last week, is it really reinforces that, as the chair's just described, we're about to create a statutory partnership which is chaired by Tim Swift, council leader in Calderdale, and has a broad representation from all of the local authorities, the NHS, the third sector and community groups in West Yorkshire, so that we can, and we're going to create a statutory body within that, an integrated care board. We didn't pick the name before anyone complains, but it's called a board, but it's an organisation, and this is the board of the integrated care board. So we're creating a statutory body which has the responsibility with its partners, local authorities, individual organisations and communities and community groups, has the responsibility of delivering the strategy. Now, in this context, I think we've got to recognise that this is a pretty vital time, and I'm really pleased that we're starting off, as we mean to go on, with living the mission, values and behaviours that we anticipate by having meetings like this in public before we are constituted, because I think it starts at the right time. A story about people who need to have a better experience, and by describing the things we might do to make that a reality. So this is a fairly vital time for us. I think we got to recognise that the strategy that we signed off in 2020, March 2020, just as the pandemic hit, set out 10 big ambitions that were addressing health inequalities, some clinical issues and our contribution to society. And that strategy is still relevant and has probably got more difficult to deliver. If we just took one example, cancer, early detection of cancer. We've got some of the finest cancer services in Europe, in Julian's organisation and beyond, but we have some poor cancer outcomes because of late presentation. Because of the downturn in people coming forward during the pandemic for concerns around cancer will have a blip on that. That's just one example. So we've got a strategy which we have to refresh and is going to become more difficult to deliver. And we now face waiting times and delays across all elements of care, whether that's in social care, mental health, primary care, the acute system, that we're going to have to address, and we're getting on with. So we've significantly reduced the number of people waiting, very long waits, for example, recently. So that double trouble, I call it, of having to deliver our strategy on inequalities, care variation, using our resources wisely, getting the biggest economic and social return that we can, and tackling waiting in the health and care system are things that we now have to do as an integrated care board within an integrated care system. So we're doing that in an interesting context where somebody, I think Hannah mentioned earlier, that poverty is becoming a substantial concern for people, cost of living is becoming a substantial concern for people, and the things that drive ill health are potentially against us. So the report talks a lot about, you know, what we're doing around our strategy, what we're doing to provide good access to good services. So I don't want to do anything other than commend the paper to the board as good context. Want the board to note that there are some strategies and areas which I think we're currently working on which address strategic risks, like how do we deliver much better intelligence and data around what's going on in the system that's joined up? How do we think about primary and community services coming together in a different way to have viable and sustainable services which are personal to people? That sort of thing. So I want people to know that we've got some work on those strategies and they will come through the work plan to the board over the next year. I want people to be aware of the involvement framework and all of the evidence in the annual reports that we publish around the engagements we've had with the public and what they're telling us. And I want people to be aware of the two pledges that we've got going on at the moment. So the first around climate change, you can see my background is about the All Hands In campaign, which is what small changes we can each make as individuals, the 100,000 people who work across health and care that could contribute to turning the curve on the climate catastrophe. And what I would commend to board members is that as role models, it'd be good for you to be involved as leaders of organisations and within your sectors. Getting behind this campaign would be really helpful. And then the second campaign, which launched yesterday, was the latest iteration of our check-in campaign. So one of our 10 big ambitions is to reduce suicide rates in West Yorkshire. Suicide is still the biggest killer of young men. 75% of people who die by suicide are men. And we have a range of evidence-based interventions that could help. One of them is to build connections and hope between individuals, and we have a range of fantastic organisations that can do that. So our latest check-in campaign is Check In With Your Mate, which is specifically aimed at men and specifically aims to get people to have the skills to have a conversation with somebody about an issue, you're okay, and to look out for the signs. And to support people, there is the Zero Suicide Alliance training. It's a 20-minute module that gives you the skills to see something, say something about it, and signpost people to services. Services are available to people every day, 24/7. So I would commend that to the board as well. So that's it from my report, and happy to take any questions.
Okay, thank you, Rob. Questions or comments from colleagues? Julian.
Thanks, Kathy. I just wanted to pick up, Rob, your point, really important one about how we are able to detect cancer earlier to drive outcomes and survival rates. An important part of that, of course, which I know you're very supportive of, is the work of the West Yorkshire Cancer Alliance and some of the technologies that we're using, like the pinpoint test, a new type of test using artificial intelligence, analysing blood together with other factors that will enable us, and we're trialling that obviously across West Yorkshire to demonstrate its efficacy, but hopefully that will serve us in terms of picking up cancer earlier, being able to more accurately target treatment and really help us with that goal of trying to improve pick-up and early detection. So many other examples, but one that's perhaps worth highlighting given we're currently rolling that out. Thanks.
Okay, thank you, Julian. Hannah.
I suppose just following up on that, I suppose the other thing that we know is that that GP primary care plays such a key role in terms of people's gateway to support, and I think that's why particularly that focus on, it feels like a very good time as a health and care system to sort of pause and think, have we got the fundamentals in place? Do people know how to book an appointment now? Do people know how to contact their GP? There's some really basics that we're sort of encouraging the thinking, because there's a lot of variation and there's quite a lot of confusion about how you do that now. And so that feels like a really important piece of work, because GPs and primary care play such an important role in people's health and care journeys.
Thank you, Hannah. And I'd add to that community pharmacy as well. I had a great visit in Bradford at Girlington Road Pharmacy recently. So how do we connect that, and particularly younger generations, if you look on occasions that did not attend rates as well. Thank you. Any other questions, comments? No. James.
Yeah, thank you, Chair. So just following on from Julian and Hannah, I suppose it's one of the things we've learnt over the last 2 years with COVID is the exacerbation, as we know, with the inequalities, but we've learnt also how we connect and connect into our communities, and we've seen that with our vaccination and seen that with primary care there, and working with our communities and in our communities there. So just picking up on things like the testing with prevention with cancer. How do we really engage with our communities there? What sort of things have we learnt over the last 2 years to kind of take that forward there? Thinking also other immunisations as well, not just the COVID vaccine there. It's about engaging and prevention there. So I think yes, it's I think what I'm saying is it's some of the learning that how we bring the learning we've had over the last couple of years to help us influence in some of our decisions there, picking up on the points that Julian's talked about in terms of the innovations that are happening there, picking up on the discussions we've had earlier about personalised care there, and using things like some of the funding, the inequalities fundings that are coming in to enable some of that to happen, with some of the things like the core 20+5 with the inequalities there. So I think there are opportunities, and we need to kind of reflect on those opportunities and make sure that we are using those opportunities, as well as looking at those risks as we talked about earlier. Thank you.
Great, thanks. And something we talked about in the citizen story, particularly about supporting people with long-term conditions. I'm just thinking also of a whole new group of people who have long COVID, and that then breaks down into different phases, whether you were in the first cohort or the second cohort, as many of you appreciate as well. Rob, did you want to respond? Did you have your hand up?
Let Tim come in first.
Okay, Tim, over to you. Would you introduce yourself?
Yeah, hi, I'm Tim Riley, Accountable Officer Leeds designate, and I just wanted to come in really picking up a couple of comments, particularly James and Hannah, and then tying it back to something Rob said. I think one of the things we really need to reflect on and work hard towards is that integrated data set, and the provision of that data, not just for us in boards to do assessments of progress and all the other things that we do, but to ensure that our professional colleagues in local communities really understand their community well enough that they can then link that data and an understanding of, for example, why certain groups are presenting late with the community work that James has talked about. And that's true population health management, and it's true personalisation. Personalisation and population health management are very closely connected. So when we talk about the data, it's very easy for boards, I think, to sometimes get very obsessed about what the data they're having and they're getting. I want us to be really obsessed about what our professionals in local communities and neighbourhoods are getting and what they're doing with it, because I think that then enables us to join up with communities to address some of the variation that we see.
Thank you, Tim. I think that's a really helpful principle for us to take forward. Just to share with you and to get into the minutes that NHS England are offering all integrated care boards in the country access to the data systems that they have, which will help us on reporting and assessment and internal point of view, as well as in summary in a public domain. So, but as Tim, you point out, that's only just part of the jigsaw, isn't it? And how we work together on that. So perhaps we can have that as a key topic taking forward to focus on how that links. If we remember that neighbourhoods should be our primary focus, as Tim is just encouraging us to do. Rob, do you want to respond, and then we'll move on to the next item?
Yeah, just to say, I mean, a couple of points. So I won't get tired of saying that primary care and general practitioners and the teams around them, including community pharmacy and others, our community nursing staff, our therapists working in the community, have been absolutely magnificent during the pandemic. And we currently are doing, if you look at general practitioners, for example, contacts are up. Numbers vary, but probably by between 20 and 25%. You know, need is up, contacts are up. All of our practices were instrumental in the biggest flu campaign we've ever had during the pandemic, and the biggest rollout of any vaccine, as were community pharmacies, any new vaccine. The fact that they have personal relationships with communities and people meant that none of that vaccine was wasted in the early days when it was so precious. They've had to reconfigure their surgeries to be digital, telephone based and face-to-face. They maintain 3 out of 5 people getting face-to-face contact. And they were instrumental in setting up, you know, COVID and non-COVID sites within our communities. That's led to, as we heard earlier, some frustration from people around access. And I think Hannah's right. We haven't been clear enough at the moment about how to access your GP. We have put out various communications about why GP is working differently in West Yorkshire, and Karen and the team have done some good work on that based on the insight. So I do think that there's something about just recognising the fantastic work that's gone on in primary care. It's not been without stress and pressure and some frustration on all sides. We need to address that. We will address that on the back of the Fuller review. Claire Fuller, a GP from elsewhere in the country and an integrated care board chief executive, is leading a review of primary care, which is due to report shortly. We'll also do work based on the work that we're doing in West Yorkshire with Carol McKenna as the senior responsible owner, but James, Steve Ollerton, people from communities helping us to think about how we deliver joined up care in all of our neighbourhoods and all of our places into the future. It's a big priority for all of us because it must be, because it's the fundamental building block of everything that we do. Whilst we're thinking about that and building on Julian's theme, we mustn't lose sight of 2 things. Firstly, there's some brilliant work going on. You know, a third of our GPs have access to technologies which allow them to roll out diagnostic tests to people which spots chronic kidney disease early. We've rolled that out in the poorest communities in West Yorkshire with support from the Academic Health Science Network. It's case found about 15,000 people with chronic kidney disease who didn't know they had it. It's saved those people from future risks and the development of that disease, and saved some people's lives. And this has happened during a pandemic when people have been under huge pressures, using new technologies, using new ways of working, using the kind of data that Tim described to highlight the sort of people we should be identifying. So that's the first thing. There's great stuff going on all the time. And then the second is that as we move towards more digital solutions, we've got to recognise that we're not just digitising current practice, and we're not going to create a digital solution that'll fit everybody. But our chances of that will be improved if we used inclusive digital transformation. which we're fortunate that Thrive by Design, which is hosted by Leeds and York Partnership on behalf of all of us, is the expert in this and is working with us and communities on how do we engage people with lived experience in the development of technologies that will support them into the future. So I think this whole primary care debate, this data, this digital debate, is something that will be a fundamental priority for us as we redevelop our strategy, and we're setting about doing it in the right way.
Thank you, Rob, and I'm glad you mentioned the strategic refresh. We know that we're going through that refresh at the moment to, based on our learning from the pandemic, the variety of government white papers that have come out, legislative changes, but also there's our learning, isn't there, and what we can see that our communities need, that we need to make sure that that's embedded. And I didn't want to lose the point, Hannah, from your earlier report about digital inclusion and exclusion as well, which then links in with a number of points that colleagues have made here as well. Okay, thank you, Rob. So we'll see a different kind of report from you from July, but as always for you and I, we're testing out the content here. So colleagues, please let us know what works and areas of development. Jane, I know in the chat box you've given some points there on what could be included at future meetings. We will have a future work plan and we will have the people plan recorded on that, and a point for the focus and discussion. Colleagues, if there is anything else you'd like to see on future agendas, please use the chat box or contact Rob or I afterwards. Okay. Thank you. We're going to move on to our next item now. Anthony Keeley and Jonathan Webb. If you'd both introduce yourself in a moment, but Anthony, particularly explain your how your role links within our partnership. This is about receiving for information our integrated care system operational plan, which we as an integrated care board will have oversight from the 1st of July. Anthony and Jonathan, I am so sorry that we are reduced on time. So I know we gave it a bigger time slot, but if you could try and give your overview in a slightly shorter time, that will help us manage time together. We note that Keith Ramsey will probably aim to join us about 1:45. Okay, Anthony and Jonathan, over to you.
Yes, thanks very much, Chair, and hello everyone. I'm Anthony Keeley. I work for NHS England and NHS Improvement. I'm the locality director for West Yorkshire. And in that role, I'm very much kind of embedded in the integrated care board and working alongside colleagues on this board. And as part of that, I coordinate the work we do on operational planning for the system. I'll just ask Jonathan to come in now and introduce himself before we go on.
Thanks, Chair. Thanks, Anthony. I'm Jonathan Webb. I'm Director of Finance Designate for the Integrated Care Board.
Thanks, Jonathan. So as the Chair says, you've got quite a detailed paper setting out the headlines of the ICS's operational plan for 22-23. It is quite a long, detailed paper, and I don't propose to go through it in detail. You'll be relieved to hear. We have prepared just a few slides, which we thought might be useful just to draw out some particular points of emphasis. So I'll just put those up, and I think they will help us get through this in a fairly swift way as well. So I guess one of the key points to make about this plan is that it isn't a comprehensive plan of everything the partnership does. It's really primarily a response to the NHS national planning guidance and priorities. Planning guidance is issued every year by the NHS and systems are asked to respond to it. This year, the guidance was framed around the 10 priorities set out on this slide. The ones that are slightly greyed out aren't covered in this particular operational plan, that they're subject to separate planning processes. So this operational plan is really the response to the 6 themes highlighted on this slide. And I thought it would be useful just to really focus on the 3 issues that are subject to particular ongoing work around the plan. That's details around the workforce plan, the elective recovery, and the finance elements of the plan. In terms of workforce, our providers have set out a set of plans which aim for a growth of just under 3% in the number of funded established posts that are available, and linked to that a growth of 4.5% in total staff in post, and that's obviously differential growth across different staff groups. Those numbers are quite ambitious and challenging, and one of the things I'll come back to at the end is just the need for us to perhaps give a bit more focus to just how achievable they are and how they link to the other elements of the plan. Those growth plans are supported by international recruitment for some organisations, for some staff groups, and we're aiming for a shift towards more permanent staff and away from bank and agency staff, as indicated by the reduction in bank and agency usage summarised on the slide there. And we're also aiming to have a reduced level of sickness absence over the course of the year, as one would hope, I suppose, coming out of the acute phase of the pandemic, and stabilisation in terms of staff turnover. One of our big priorities, again, coming out of the pandemic, is to really get back to sort of pre-COVID levels of planned care and elective procedures. The NHS have set the challenge of getting to 104% of pre-pandemic levels of activity as measured by the cost-weighted value of that activity. And thankfully, our plan is in line with that. We're aiming for 105%. And we're also aiming to make big reductions in the numbers of people who've had to wait a long time for their elective care. So by the end of June, we aim to have nobody waiting more than 104 weeks, 2 years for their planned procedure. We're still managing some risks around that, but we've already reduced the possible cohort of people in that position by 90% since around October. And then going further, we aim to have nobody waiting longer than 78 weeks by the end of March, and nobody waiting more than 52 weeks by 2025, and making good progress towards that during this year. We still have some work to do to understand exactly how much diagnostic activity we'll be in a position to deliver. Our plan isn't yet in line with the national expectation of 120% of pre-pandemic levels. So that's one of the areas we're still looking at. And the cancer plans are very much in line with national expectations around improving access to cancer services. I'm going to hand over to Jonathan just to outline some of the headlines of where we are with the finances.
Okay, thanks, Anthony. So what this represents is the position that we submitted to NHS England at the end of April, and it covers the NHS system financial plan for 22-23. So we have got a system revenue allocation of £4.8 billion, and we distribute that all through to our 5 places. What we've done as a system is to build up our plans from organisational level. So they're very much sort of bottom up, owned by organisation, owned by place, and then overseen through system. And that covers 5 CCGs and 10 providers. So that this planning position has been through individual governance review, place review, and also system review. The financial plan is clearly one element of an activity, performance, workforce and quality plan. And where we landed in our last iteration of the plans was to have a £73 million planning gap against our £4.8 billion allocation, which is 1.5% of our total allocation. And I should stress that remains work in progress. Some of the reasons that sit behind that planning gap are listed in the bullet points on the slide in front of you. So one thing that we we're experiencing, as indeed as other parts of the country are, is the issue around inflationary pressures that are significantly higher than they were when the autumn 21 spending review was set. Obviously related to the conflict in Ukraine and the ongoing impact on utilities costs, and also any of our contracts that we have which are related to RPI or CPI, so inflation-linked contracts. What we're also seeing is that the expected level of reduction in COVID costs isn't quite playing through in terms of matching the reduction in allocation that we've experienced in 22-23. So in brief, due to patient flow issues based on sort of IPC issues, the amount of reduction in our allocation isn't matched by a corresponding reduction in costs. I think it is worthwhile just touching briefly on elective recovery funding. So Anthony mentioned just a moment ago that our elective plans are predicated upon delivering 105% of 1920 levels of planned care. And indeed, our financial plans are based on a similar sort of basis. The way that the funding model will work in 22-23 is that we as a system will either receive additional resource or will have a reduction in resource if we don't deliver that 104% target level nationally. And what that gives us is very little wiggle room if we're not able to deliver that level of activity without a corresponding reduction in cost. So we haven't been able in our plans this year, given that overall position, to provide any form of contingency cover for that, and that remains a risk. Our position does rely to an extent on non-recurrent measures, and because of that we do have an underlying deficit as a system that clearly we will need to work on during the year as we start to get into 23-24. And for completeness, it's worthwhile saying that we do have a system capital allocation of 158 million for 22-23, and we have got fully committed plans to spend that, and a further 5%, which is an allowable overcommitment within NHS England's guidance. So in terms of the process we've been through to date, clearly with that size of deficit, which is a financial challenge for us, all organisations have been involved extensively in reviewing their own plans and place a review of plans. We've utilised the West Yorkshire Finance Forum on a weekly basis to review plans and to use our principles around mutual accountability and peer review. We've also engaged a number of colleagues across the collaboratives, NHS England and the ICS core team on deep dive reviews into 4 organisations. And we've also had escalation meetings in place, including, where appropriate, involving the 2 other ICSs in in Yorkshire and Humber in relation to Yorkshire ambulance services. So in terms of next steps for us, a big focus on efficiency, productivity and waste reduction, not least to prepare for 23-24, which, as I say, we expect to be challenging as well as this year. We are looking at where there may be opportunities for common approaches which might be beneficial. And as I mentioned, we're talking to the other 2 ICSs in Yorkshire and Humber about Yorkshire ambulance services. We're also looking to roll out some form of self-assessment in terms of the measures and steps that might be put in place in organisations and in places to work on financial sustainability. And I guess the last point is that whilst we did submit a deficit plan at the end of April, we are still waiting to understand how that will play out nationally and what the national response to that position will be for us. And I expect we'll be able to brief further when we meet again in July. Thank you.
Thanks, Jonathan. So hopefully members will gather there are some risks in terms of being able to deliver the key elements of this plan, that those risks are summarised here. They relate to pressure on workforce supply, and I mentioned the ambitious workforce growth targets at the beginning. We'll also have a number of challenges around delivering the elective growth that we've outlined, not least if we have further waves of COVID pressures and also further ongoing seasonal pressures that we've been responding to right throughout the pandemic. Jonathan's outlined how tight the financial position is, and we should also flag that we've got a very clear focus in this partnership on reducing health inequalities in the way we implement our plan. That remains the ambition and the intention, but we should just flag the risks around the constraints on that, given the need to really maximise delivery of patient activity. So finally, where do we go next with this? We are working now to triangulate the finance activity and workforce plans just to understand the extent to which we're on top of the risks around them. We will be working on the health inequalities impact of the elective care plans just to make sure that we are managing the risk I've just highlighted. Jonathan talked about needing to assess the quality impact of the efficiency plans, which are quite stretching across many organisations. And we're also aiming to put in place new capacity to support the growth in elective activity. And that includes some nationally funded capital schemes across a number of sites in West Yorkshire to create dedicated, what we call green elective care sites, which aren't subject to pressures of urgent and emergency care. We are still dealing with a lot of urgent and emergency care pressure across our system, and that is constraining at sometimes the levels of elective activity we can achieve. And we're also focusing on trying to manage risk as effectively as possible, particularly around areas like ambulance handovers and flow around the system. So that's the slides, and sorry for rattling through that at pace. I hope that gives an indication of the sort of key themes of the plan. We're really looking for the Shadow Board Chair to note the detail of the plan and to consider our collective role in supporting its delivery through the rest of the year.
Okay, thank you very much. Yes, so we are not a statutory body yet, so this is very much for information as Anthony has outlined. Are there any questions or comments at all, just sort of how we think this through together, have oversight of this from the 1st of July? Hannah?
But just picking up on that point about the risk around health inequalities, Anthony, and you mentioned health inequalities is going to be part of some of the elements, but can we make it part of all the different elements that we've got here? Because I can see it in some of them, but not all of them, and that presumably is a way to make sure that we still keep focusing on health inequalities.
Anthony, I can see you nodding.
Yes, if you'd like me to respond, Chair. Yes, absolutely, Hannah, agree with that entirely. I think what the paper hasn't done justice to is the very detailed health inequalities plan that kind of underpins the breadth of what we're doing, and that will remain front and centre of how we approach this the delivery of this plan. So yes, that's a key point. I agree.
Thank you, Hannah. We've got to embed it in all we do, haven't we? Jane, then Ian.
Thanks, Kathy, and thanks, Anthony and Jonathan. I think actually it was a really good overview, so thank you for that, because it's a complicated beast, I'm sure, in getting to that. But I think it was really, certainly as a new member onto the board, it was really helpful. I guess, and I think some of my comment reflection will feed into maybe some of this afternoon's and other board development discussions. But the sort of, you know, in your next steps, we talk about the quality, assessing the quality impact of efficiency plans, and thinking about how at a board level we get assurance or what we see to give us comfort that that has been appropriately, you know, sort of reviewed, considered, and, you know, what are the challenges, you know, actions to be taken to mitigate those. I think is a helpful one to think about maybe when we get into our discussions around governance and board versus places, etc. But I think overall it was a really helpful review. So thank you for that.
I think Kathy might have frozen.
Chair might be frozen. Yeah, we'll just respond to Jane. Well, hopefully Kathy's unfreezing. Yes, and that's absolutely right. And we will look to bring back later in the year a review of the work that's been done to look at the quality impact of efficiency plans.
Yeah, just to add to that, while we're waiting for Kathy to come back, all organisations in the system, you know, we need a good system. We need good organisations, and all organisations routinely do quality impact assessments on their, you'll know this from your previous experience, Jane, on their efficiency plans. And what we need to do is to make sure that those are robust, and where we are, you know, expecting more allocative type efficiencies through system change, that we've got a good approach, I think. So I do think it's a good challenge, but we should be assured that, you know, we have organisations that generally pretty good when it comes to CQC ratings on things like quality impact. And as you say, Jane, when we go into the development sessions around the way that the quality surveillance group and the system quality group are going to work in the future, we need to make sure that we're rock solid on this, because the degree of risk is significant.
Should we bring Ian in next?
Thanks, Anthony. Hi, everyone. I'm Ian Holmes. I'm Director of Strategy and Partnerships Designate for the ICB. It's just a comment, really, and it's something that Jonathan and I have discussed previously. We touched on the 5-year strategy in the last item, and our ambitions around a longer term strategy which focuses on inequalities and outcomes and will require changing patterns of service delivery, and what some of this stuff feels like is quite a sort of a short-term operational plan, particularly the finance plan. So one of the pieces of work that we'll be doing over the summer in parallel with the 5-year strategy refresh is how we kind of allow ourselves to take a longer-term view on the finance. So we're not sort of just focusing on the annual cycle. So it's just to provide a bit of assurance that that work's happening in parallel.
Indeed. Thanks, Ian. And Hilary?
Thank you. Hilary Thompson, the voluntary sector interim board member. Thank you for the presentation. I just think we need to be mindful that there'll be high expectations of the public of this new body and how we can recover and all the rest of it. And with the financial restraint that we've got and the workforce challenges, I think we have to be very, very careful with our communications out to the general public, not to get expectations too high and to be realistic. So I just hope there's some sort of narrative going forward that we can all use to inform people properly what the situation is.
Yeah, that's a really good challenge, Hilary, and we'll take that one away in terms of thinking about how we frame the messages appropriately. It's obviously right that we challenge ourselves to be as ambitious as possible about recovering as much activity as possible through this plan, but we need to, I should say, be realistic with the public about what to expect. Jonathan?
Thanks, Anthony. I think Kathy might be back as well now. It was just to pick up the point that Hilary made, really, because I think it's really important to know that the numbers that I've described today are a work in progress and they are not the final plans of the Integrated Care Board. Having said that, I thought it was really important in the spirit of openness and honesty to bring in updates to the newly constituted board to at least let colleagues know where things were up to. So I recognise the point that you've mentioned, Hilary. The communication around this is important, but I should stress this is a work in progress, not the final set of financial plans for the Integrated Care Board and the system for this year.
Thank you. Colleagues, can you hear me? Have I unfrozen? Yes, good. I'm on a different device, thanks to Lucy. Okay, we've got comments then from Fatima and Rob, and then we'll get on to our last item. Fatima.
So completely support what Hilary's just said about public expectation, but also wonder whether we're utilising enough the opportunity that personalisation provides to support people that are waiting to access care, because actually if people are able to manage their pain or feel like they've got a better quality of life, they're happy to wait. It's when they're in the discomfort or they can't manage that the anxiety or frustration manifests. So I know we've done some work on that, and I just want to make sure that we keep the momentum on that going. I suppose my other sort of reflection as well, and it is something very much on our radar, is how we support our people with the delivery of this. I've done some recent walkabouts in another role on some sort of acute sites, and it was not lost on me how genuinely people are tired, how the need for them to be able to catch breath, reflect, repivot is so important. So while we're balancing the expectation of delivery and the ask from all directions, what we can't do is lose sight of the individuals that we're expecting to deliver this and the very real need that they will have to recover and also to motivate them to continue to keep going, because I know that many are still struggling.
Mm-hmm. Thank you very much, Fatima. Something I particularly want to plan for us as an integrated care board is how we get out on the ground to meet colleagues in service delivery of all the different kinds across different sectors and in our neighbourhoods. So many of you do this on a number of occasions through your service provision, but how do we do that in a meaningful and effective way for us as integrated care board members as well? Rob, is there anything you want to add? And then we'll go over to our next item.
Yeah, so just to reinforce Fatima's point about staff, so public expectations we need to manage good and what limitations there may be, but we also need to give staff hope about the fact we've got reasonable, credible plans that we own that they can touch and feel are meaningful to them. And I think that's as much part of the next steps as everything else. I think staff have been amazing over the last couple of years, and every time we ask them to do something, they deliver it. And they can do that more if we can give them some hope around what's happening next. So I think that's the first thing I just wanted to reinforce. I think that the second thing was just to pull out that, as we've heard, this is a partial bit of our planning. It's a big part, but it's not everything. And there are separate plans being requested from NHS England on mental health against the Mental Health Investment Standard, separate plans on cancer and cancer delivery in detail. I know I've got the headlines here. We'll have to have recovery plans and assurance around Ockenden and maternity, rightly so, I think. And we've got the broader work of councils. Now, I didn't know if you wanted to get any quick comments on mental health, cancer, maternity, and sort of broader council work from, we've got Sarah on the call from mental health, we've got Julian as chair of the Cancer Alliance, we've got Bev's been doing work with Carol and others on Ockenden, and we've got Robin and Joe and others who are joint appointments with councils. So I don't know if it was worth just getting a couple of minutes on those things.
I don't know if anyone unprompted would like to share their thoughts, but I think actually there's a key thing here, Rob. We've got to weave this all in. And it's one of the points I wanted to make in this meeting and in our future development sessions about how we navigate. And this is a principle we all agree together at our partnership board, that we give equal weighting to the plans and priorities within our communities and our health and wellbeing boards and place committees alongside NHS England requirements. And we have to deliver both. I don't know who's let me just find that. You have to bear with me because I'm on a different device. Bev, Robin, Julian, and then we will definitely come to you, Keith, because I can see you've joined the meeting and you're waiting patiently. Bev first.
Okay, so I'll just give a couple of minutes on Ockenden, if that's okay, Chair. So interestingly, I came from the LMS meeting and came to this meeting this morning, and a big feature of that clearly was the Ockenden report and the second iteration of the report that were published in April. You'll know, but I feel I have to repeat it, that this is the report into the independent review into midwifery maternity services at Shrewsbury and Telford, backdates 20 years and found some quite disturbing themes and trends, many of which were already identified in the previous Kirkuk report that was published in 2015. 4 key areas of focus, which were around safe staffing, a well-trained workforce, learning from incidents, and listening to families. And each organisation, each provider organisation that has maternity services has had to give a public update, an update in public board in April against their actions from the 7 essential actions that were identified in 2020 when the first report was published. We've got really detailed action plans in each organisation, and that the oversight is seen at the LMS board. And I think following this morning's board meeting and some of the conversations that happened there, I think we're going to have a stock take about the information that comes, and also what's fed up in terms of detail, but also the oversight and mitigation of risk from a system level. I'm going to stop there because, as I've said, there's lots of work, and I just wanted to give some assurance to the board that there is it's ongoing, the work. It started in 2020. All provider organisations have got robust action plans that have got their board oversight in public, and we're looking at system risks at that level. Thank you.
Thanks, Bev. Robin, then Julian.
Yeah, thank you, Chair. So I'm Robin Tuddenham. I'm the designate place lead for Calderdale, one of the 5 authorities. I'm also the chief executive of the local authority. Very busy time, as you'll know. Local elections have just happened, and we are in the midst of forming the new administrations in all the 5 councils. And I think just the point I'd make is that I know that the ICB will focus on the conditions and the environment around people's health and well-being, and is developing a deep relationship with the mayoral combined authority around the things that actually do determine people's health. And there is both joint posts, collaboration, shared thinking, and policy development, I think, in the short, medium and longer term, because the factors that the mayor has in her pledges, like affordable homes, warmth, climate change, supporting people around better transport, are fundamental factors which will shape the health and the wellness of the 2.3 million people in West Yorkshire. Just to say that, and then the other thing to say is that the relationships will be inherently close between the place-based committees and the health and wellbeing boards, and we're just at a point where we're reconfirming the new chairs of the health and wellbeing board. So I think the relationship to democratic accountability in place will be inherent in the way we shape and design our work as a system. Thank you.
Thanks, Robin. That's very comprehensive. And as we know, we have a joint public health role with the West Yorkshire Combined Authority, and we've been doing mapping exercises against our 10 big ambitions as a healthcare partnership, alongside the mayoral ambitions, as well as the overall Combined Authority plan. So more on that soon. Julian, and then we're definitely coming to you, Keith. Bear with us.
Thanks very much, Kathy. Yes, just to emphasise the importance for the West Yorkshire Cancer Alliance of the engagement and patient voice, and I think we're off to a great start with the Cancer Patient Panel winning the Help Force Partnership and System Working in Volunteering Award, and there's a great patient voice and participation as part of the West Yorkshire Cancer Alliance, coupled with the importance that I alluded to earlier about innovation. And with the Academic Health Science Network, we've launched 10 innovation schemes, which include breast cancer surgery, improving screening uptake in minority communities, and onco-geriatric programs to support best care options for older people. We've got now increased capacity for targeted lung health checks, which are basing themselves around all parts of West Yorkshire, easily accessible. I mentioned the pinpoint blood test, which is helping to deliver our ambition of at least 1,000 more people offered curative treatment, and raising awareness and supporting early identification of oral cancer, which is increasingly vital as part of our Health Equity Fellowship to improve access to services for high-risk groups. So there's a lot going on to ensure that we've got the connectivity with our communities, as well as, of course, what we heard from Anthony about the must-dos in relation to cancer waiting times, all of the key targets that we know we need to deliver. We're working across the West Yorkshire Association of Acute Trusts to manage that collectively, and we've got some really important work going on at the moment to improve and develop oncology services for access to all our patients, to make sure that that's a service that's resilient and sustainable for years to come. So thank you.
Thank you very much. So from Bev, Robin and Julian, we've got some thematic areas there that we can look at, both as best practice, but also as areas of learning and quality improvement. Thank you for those contributions. Okay, we're now going to go on to our last item on the agenda, which is a report from our... Oh, Rob, did you want to come back?
Just to say that this report, I know you asked at the beginning about anyone declaring interests. Obviously, the Shadow Remuneration Committee has considered the director pay for people and the non-exec director pay. So I suspect that we would want people directly affected by that to take that into account in any contributions during this conversation.
Thank you very much, Rob. That was one of my notes. Thank you. I appreciate that. And this is the tension that we have, hopefully, in our good governance arrangements. Thanks, Rob. Keith, a warm welcome to you, and I really want to thank you in stepping up to be the chair of our only Integrated Care Board Shadow Committee and supporting us in making sure we've got oversight and scrutiny. Are you there?
Yeah, I'm here.
Brilliant. Would you introduce yourself, Keith, particularly for people that maybe don't know you?
Yeah, so I'm Keith Ramsey. I'm chair of the board at Mid Yorkshire Hospitals NHS Trust, and as Kathy said, I've been chair of the Shadow Remcom of the Shadow ICB for the past few months, along with colleagues from other providers and CCG, Remcom lay chairs within the West Yorkshire and Harrogate system. And Kathy was a member too, and we've been supported by officers. So this is a very short report, Chair, as we discussed. It just gives, I hope, the Shadow ICB a bit of assurance about what we've been doing. I welcome the comments from Rob and yourself about declarations of interest, because I think probably the majority of people's remuneration sitting around this table has been authorised and approved by the Shadow Board, and that will then go on to the statutory REMCOM committee when it starts in about 6 weeks' time. So I've only got two things to add that I wanted to highlight. I think it was a point that Hilary made about high expectations of the public, and so the 2 points I bring out here is that we've made a real big effort to make sure we carried out our fiduciary responsibilities, because this is public money. There's a significant, substantial sum of public money tied up in all sorts of salaries at senior levels and across the NHS. So we were really keen about that. We treated this as it was our own trust, it was our own board, our own REMCOM. And the second point, which is referred, and is what I know is ongoing, is we very much instigated and supported the review of the recruitment processes, because while there's been a lot of work done with Odgers, the number of candidates to get to the various non-exec member positions within the board, we still think there's some more work to do around diversity, and I think you can probably see that for yourselves on the screen. So whilst across the the ICS and the various jigsaw pieces, we're getting better at distributed leadership, I think one of the things that did concern us was the ICB right at the heart of it. It's probably got a bit more work to do, and I know there's a fourth NEM vacancy currently out there, so we hope that whoever's doing your recruitment in this one kind of just goes the extra mile. I don't think I have anything else to really add. I'm happy to take any questions from board members, shadow board members.
Great. Thank you, Keith.
This becomes really kind of thinking, you dipping over your tongue, thinking, are they shadow? Are they not? Or are they tripping? So anyway, great on the 1st of July at midnight when you get there.
Thank you so much, Keith, and I very much appreciate the time and scrutiny that you've undertaken for us. We've had robust conversations, because I know not every integrated care board has had such a committee. Bob, I just wanted to invite you just to talk about the equal pay principle, because you very much worked with Keith, myself and other members of the committee on making sure we've got some key principles around remuneration. I don't know, just in a minute, whether you just talk about the equal pay principle.
Sure, I think so. We're obviously operating within a framework of national guidance, which is itself based on job evaluation. We haven't seen the formal job evaluations upon which it's based, but it is based on those things, and it has a range of pay ranges which we operate within. Some are the same, some are different, and we've started from the principle that they should be the same if possible, and then we take account of individual circumstances where required. And that came from a recognition that some roles within organisations, for example, Director of People, Director of Nursing, tend to be more dominated by female members of staff, and some roles, Director of Finance, for example, tend to be more dominated by men. So we wanted to try and equalise that. There is a gender pay gap in the NHS, and we want to show some leadership around some of that. So we try to adopt a set of principles that would do something about that by trying to get equal pay for equal work.
Thank you very much, Rob. And just to reflect, this committee has been meeting about once every 6 to 8 weeks or so. Particularly, it's been an incredibly busy time in terms of recruitment. Our last meeting was a very robust discussion on commitment to diversity across all our leadership roles, but particularly our integrated care board. So, as I said at the start of the meeting, the pausing of the recruitment of the 4th integrated care board. Independent non-exec, that's such a long title, is one of the examples of that, and bringing in the Race Equality Network much more closely to be a critical friend, but we have a lot more to do, and that will inform the last appointments through nomination or recruitment process. So Keith, I'm grateful to you and many others for a very robust conversation, one tea time through one of our meetings. I think that's it. Keith, you don't seem to have any questions or comments from colleagues, so and I know one of the things that we've agreed to do right from the start when this group started meeting in January is to make sure we've got a robust handover to the independent non-execs who are going to take over from you and make sure that's smooth. I don't know if there's anything you want to say before you go, Keith.
No, I was going to say we meet again, and the final meeting's the 14th of June, and whoever is the new chair of the statutory body, happy to touch base with them prior to the 1st of July, which we can arrange.
Great. Thanks again, Keith. I appreciate your time, and I'm sorry we're running late. We had a
thank you. Bye-bye.
Technical difficulty. Bye-bye. Thank you. So colleagues, we've got a number of things there. I am going to finish this meeting up very quickly, but we've had a number of things to note out of all those meetings. It has been a for information meeting, but there are a number of principles there that we're going to take forward, as well as seeing the operating plan, which gives us the NHS England NHSE oversight and scrutiny that we need to be considering together. I will let you now have a lunch break because I know we're going to then move into an informal development session to support us as a brand new board in working together. Thank you to everyone who prepared reports and contributed today, and we hope for members of the public and stakeholders across our partnership this was a helpful insight into the beginnings of our integrated care board for West Yorkshire. So thank you, colleagues, and we'll see you, I suggest, at 1:20, which keeps to the break that we were having. Thank you very much.